Good day, everyone, and thank you for inviting me to speak at this wonderful symposium. I'm so sad to not be joining you in Alaska. I enjoyed the last time I got to attend a few years ago, and I hope to be back at some point. But this has been a really nice opportunity to bring us all together virtually. And I'm really pleased. I'm going to give kind of a rapid fire overview of developmental therapeutics, mainly in ovarian cancer, but then we can answer questions during the Q&A if you have questions about other disease types. These are my disclosures. So I'm going to just start with what's the problem here? What's the problem with ovarian cancer other than the obvious that we have it at all? And the big problem really is that despite exquisite chemosensitivity for most women who present with ovarian cancer when they are treatment naive, and that response to initial chemotherapy can sometimes last for years. For the vast majority of women, 80% in fact, you'll recur within three years. And once recurred, we have many, many things to treat you with, which is great, but the likelihood of cure is little to none. And so that's first and foremost the big problem. The second problem is that once we've recurred, although we have many things, with increasing exposure to new therapeutics, cancers are unfortunately smart and they develop emerging resistances that we have to overcome. So there's two big problems that face us in developmental therapeutics. How do we overcome those challenges? And so when we have recurrences and development of resistance, this is what it leads to. And this is an example of one patient's journey with ovarian cancer. If you start on the left, you present with a very elevated CA-125 and a lot of disease. It all goes away with surgery and chemotherapy, but over time, unfortunately, it will recur and we'll retreat with platinum. And we may do that several times, but each successive exposure to platinum, you get less of a robust response, and the duration of time that you buy with that line of therapy gets shorter until such time that we don't get responses to platinum anymore, and we have to use non-platinum types of drugs instead, with kind of marginal efficacy. And so we have a big mountain to climb, just to use the theme of this conference, to improve upon that. We have made significant progress though, so it's not all bad news. When we think about the about 22% of women who have BRCA-associated cancers, either because they were born with a BRCA mutation or their tumor harbors one, we've made amazing strides in the past really just 3 years with incorporations of PARP inhibitors as maintenance therapy with or without the drug bevacizumab, or you know it as Avastin. And so I'm putting the 3 big studies up here just to show you unprecedented improvements in progression-free survival, basically a 70% reduction in the risk of progression or death with use of a PARP inhibitor based on SOLO-1 for 2 years. Prima has it out to 3 years, although we haven't followed patients long enough on that study yet. So that kind of remains to be seen if it's 2 to 3 years, but regardless, at least 2 years. So unprecedented improvement in really the new standard of care. The other thing that's emerged with these studies is really a new understanding of biomarkers, not perfect, but a new understanding of biomarkers. So you have BRCA-associated cancers. We have this new classification of tumors that are called homologous recombination deficient, or they might be called loss of heterozygosity, LOH high. And basically what that means is those tumors, for many reasons, have trouble fixing their DNA. And so when you use drugs that damage DNA, like carboplatin or a PARP inhibitor, if a tumor inherently struggles to fix its DNA, it's unlikely to be able to fix whatever damage that agent has caused, and it will die, which is what we want. And so they're more sensitive tumors. And so these tumors and women with these tumors also benefited tremendously with use of PARP inhibitors, again, with or without bevacizumab, with about 50 to 60% reduction in the risk of progression or death with use of a PARP inhibitor for the same amount of times. Not perfect. We can improve upon this, but still unprecedented improvement, and I think the new standard of care in this particular biomarker as well. But what about the tumors that are what we're right now classifying, again, imperfect assays, this is what we have, who are classified as homologous recombination proficient. And so these are tumors whose they have a good ability to fix themselves. which we want for our normal tumors. We want our normal cells. We want our normal cells to be able to fix damage. That's how we keep being like functional human beings. But we don't want our tumor cells to be good at that, because when we use drugs that damage DNA, if they can just fix it, they're just going to live right on through that chemotherapy and be resistant, or more likely to develop resistance. And so this group of tumors, and it's 40-ish% of tumors are considered homologous recombination proficient or loss of heterozygosity low. It kind of identifies a group of patients whose prognosis is a little bit poorer than what we would want, and whose benefit from PARP inhibitors isn't zero, but it's not as high as the other groups. And so clearly a group that needs our attention. Unfortunately, there's a number of studies that are ongoing that may answer kind of how we can do better here. But a lot of us hoped that immunotherapy would save the day for this group of patients and others. But unfortunately, we've done two big studies, big randomized phase 3 studies. The first was Javelin 100 that incorporated the anti-PD-L1 inhibitor avelumab with chemotherapy, was very negative, and it actually was stopped early because it was negative. And then sadly, this is my study, Imagine 50, which combined the PD-1 inhibitor atezolizumab with bevacizumab or Avastin and chemotherapy and maintenance. And we looked at the whole all comers, and then we looked at patients with what we thought was the immune biomarker, PD-L1, both as primary endpoints. And we got a really insignificant improvement bump in the progression-free survival, not warranting addition of atezolizumab at this time. So 2 negative phase 3 studies, but signals in this and some other studies I'm going to talk about that maybe some other combination therapies, will be effective. And so more to come on that. But right now, immunotherapy is not quite saving the day. Now, there are a number of studies that have completed accrual or just about to complete accrual, and I'm going to kind of just rapid fire go through these. The first we should hear about is Athena, which looked at a PARP inhibitor with or without an immune therapy. We should hear that result maybe in the next year. And then there's several studies that are variations on a theme of a PARP inhibitor plus an immune therapy plus or minus Avastin. And so that's Keylink, that's FIRST, and that's what we call DUO-O. And all of these are either done with accrual or very close. And so probably we're looking at results reading out in 2022. And I'm interested in these because of this question of the homologous recombination proficient group. And the reason I'm interested is because of this study. So this is called Mediola. Mediola was done in women with recurrent ovarian cancer that was still platinum sensitive. So not like frontline, but not resistant yet. And it looked at the triplet of a PARP inhibitor, olaparib, an immune therapy, durvalumab, and Avastin, versus a PARP inhibitor and immune therapy doublet. So triplet versus a doublet, no chemotherapy. And it looked at them in those different biomarker subgroups. It's a small study, but it was really interesting because what you see here is that the triplet, patients on the triplet did really well. Like almost all of them responded, their tumors shrunk to some degree. And so you can see that on the left. But if you look at the bottom, LOH positive are those group of patients we expect to respond to PARP or carboplatin, and 100% of them responded. So that's great, but kind of expected. But the LOH negative group, this is the group of patients I was telling you about that I'm worried about, that homologous recombination proficient group. 75% of them responded to the triplet, whereas the doublet of only a PARP plus immunotherapy, only 17% responded. So the PARP plus immunotherapy plus Avastin may have some magic to it. And 3 of those big ongoing studies are that combination, and they're all stratified by homologous recombination deficient or proficient. So we're going to have a lot of patients receiving this triplet as maintenance in that certain biomarker. So we should get a signal of whether or not 3 drugs for maintenance should be considered in that group or not. And so I'm kind of excited about that. The other thing to hear about that's sort of totally different is this drug origavimab. And so origavimab has been around for a long time. It is a monoclonal antibody that targets CA125. And when it binds to CA125, it initiates this immune response. So it kind of tries to initiate an immune response that otherwise doesn't exist naturally with your immune system responding to the ovarian cancer. There have been a couple tries with this drug in phase 3 settings that haven't worked, but they finally timed it with chemotherapy. They didn't use it as a maintenance. They used it with chemotherapy in women who had their tumors completely resected in a small phase 2 randomized study. But they showed an overall survival advantage and progression-free. That's on the left, but on the right-hand side, overall survival. You don't see that very often. So this led to some excitement and a study that's just initiating. This is Gynecologic Oncology Group Protocol 3035. It's led by Dr. Angeles Alvarez-Secord, who's one of the faculty this weekend, so you can ask her about this. It's in patients receiving frontline surgery or interval surgery. The schedules of drug are a little different, but it incorporates origavimab with chemotherapy only in patients for whom you're not planning on using a PARP. So you can't have a BRCA mutation. And if you're HRD and you're planning on using a PARP, this is not the study for that patient. For patients for whom PARP is not considered the standard of care. So mostly homologous recombination proficient. So this would be an interesting study for us to look at, and it's just launching. So this begs the question, now that we're using potentially all of our current best agents up front, PARP inhibitors, and you can use bevacizumab with it or Avastin, what do we do for the patients who recur and are platinum sensitive? What do we do for them other than platinum-based chemotherapy? So what do we do at this point? Well, we had all these PARP inhibitors that were approved initially in this space, and we were really excited about that. We've moved them up front now. So the question is, can you use them again? And so this is the study Oreo that's answering that question. This is done with accrual. I actually don't know the readout for it yet, but it's asking the very simple question. If you received a PARP inhibitor already and you're platinum sensitive and you respond again to your platinum, they randomize to olaparib or placebo. And the question is, does the olaparib work again for whatever PARP you got the first time? And it's randomized by BRCA. So a very simple question, but a very important question because we're already facing patients who've seen a PARP and we need to know what to do in that line of therapy. But the other thing that we're doing as investigators is really looking at the science behind patients who are resistant to PARP and patients who've just been exposed to PARP but may not be resistant to PARP, and trying to figure out the differences. And these are really small science-based studies and way too many to present to you today. This is just one example by Stephanie LaRue from Princess Margaret in Canada, where she looked at patients who had progressed on a PARP and then gave them combination PARP plus an anti-angiogenic agent called cediranib and looked at responses and did a lot of biopsies trying to figure out mechanisms of resistance. This paper was just published in Lancet, super interesting. Not a lot of responses seen, but this may be a very individualized therapeutic decision. We're really just learning what to do with patients who have progressed on PARP. So really just to say to you, a lot of work yet to be done. So what do we do when we get to a point where platinum is no longer considered effective, or tumors that are platinum resistant here? And maybe third line, and maybe fourth line or fifth line. I just put the arrow at third line. So anti-angiogenic agents, and I've talked about bevacizumab, you know it as Avastin, is the standard of care. Angiogenesis is the process by which we make blood vessels, and it's the process by which tumors trick your body into making blood vessels so to feed them. And so being anti-angiogenic means we're taking out tumor blood vessels to try and starve the tumor. And Avastin, again, is first in class here. The study really established a standard of care, which is bevacizumab plus pegylated liposomal doxorubicin or Doxil, Taxol weekly, or topotecan, as compared to chemo alone. And so that is the frontline standard of care for platinum-resistant disease, and it works really well for a while. But it's not curative, and then we need other things. And so then, as standard of care, we're kind of left with monotherapy chemo options that are really marginally effective. So we're looking for new things. So the new things that we're looking at that are the most exciting, there's a few, but antibody drug conjugates are very exciting. These are, again, antibodies that are programmed to something that's just on your tumor and not on your normal cells. So it's targeting, it's like a bomb, a smart bomb to your tumor, and it carries a payload on its tail of highly potent chemotherapy, totally dissimilar from anything you would be offered otherwise. Very, very, very potent. And it's on the antibodies, so it's circulating in your blood, it's inactive. But when it hits the tumor thinks it's a friend, and here's a little schematic of it binding. The tumor thinks it's a friend and like makes a little, like hugs it and brings it inside the cell, and then releases it inside the cell, and then realizes it made a big mistake and tries to kill it. And in doing so, releases these molecules of chemotherapy inside the cancer cell. So the cancer cell hopefully will die. And then the little molecules of chemo may hit tumor cells surrounding that tumor cell, and you get a little bit of a bystander effect. So it's targeted chemo. That's what these antibody drug conjugates are, like a Trojan horse. And there's several in development, and they're very exciting, but a couple have entered phase 2 and 3 testing. The first targets something called NaPi2b. NaPi2b is a sodium phosphate transporter, and it's on the surface of most ovarian cancer cells to some degree. There's different levels, but it's a very good target because it's not on normal cells. And so we like, it's been looked at already. Genentech made a NaPi2b antibody-drug conjugate. It was called lifastuzumab, and it went to phase 2 testing versus Doxil. And as you can see here, looked better. We were all really excited about it, but Genentech has really high standards, and it just wasn't like better enough to move it into phase 3. And so it kind of killed the program, which was, made us all really sad that worked on this drug. But Mersana has come back around with another molecule, still different, but it targets the same protein. It just got a name the other day. It's called upafitamab. We're calling it UpRi. And it targets NaPi2b. And this is its phase 1 data as presented by Erica Hamilton at ESMO this year, where we saw tumor shrinkage in 67% of the participants on a phase 1 study. So that's a pretty nice signal. And the higher the amount of NaPi expression you had, the longer the duration of the response, which is also what you want to see. So this is a pretty promising agent. It is entering a big phase 2 registration enabling study called UPLIFT, or Gynecologic Oncology Protocol 3048. And they are site selecting for this now. And so this will hopefully establish another agent, if it's positive, get us an approval and get this available to women off clinical trial in maybe the next couple of years. So pretty exciting. The other big target is folate receptor alpha. Again, one that's commonly overexpressed in ovarian cancer. It's not on normal cells. We can test for it. This one already has made it all the way into phase 3 testing in a study called Forward 1, which is a randomized phase 3 study of mirvetuximab, MIRV, versus chemotherapy. And it was supposed to be in folate receptor alpha medium or high expressing tumors. And unfortunately, we missed our statistical endpoint. I've highlighted here the folate receptor alpha high population, where the response rate looked better, overall survival looked a little better, progression-free survival, there were all signals towards it being better, but statistically it missed our preset endpoint. So it was a negative study, which was really unexpected. And what we figured out is that, I can say this, the vendor that did the testing that allowed patients to come on the study messed up, basically, and didn't score the folate receptor alpha correctly. So we had a lot of patients enrolled who actually didn't have enough expression to actually be on the trial. So when we restained all the tissues correctly, what you see in red is what we originally expected to see. So you can see the overall response rate is 30% versus 6%, and statistically significant improvement in progression-free survival. Now, this can't be used for an FDA filing, unfortunately, but it did justify redoing the study. So this is a redo of Forward 1. It's called Mirasol. It's ongoing now in folate receptor alpha high tumors, which is only 40% of high-grade serous ovarian cancer. So it is a subgroup. It's biomarker selected, which is kind of what you want. Select the patients who are going to do the best. But I hope that this allows us to cross the finish line and get this active agent available for you all as well. Now, I talked about anti-angiogenic agents like Avastin. Now, people get Avastin, and I said it works for a while and then it stops working. What can we do to capitalize on this responsiveness to anti-angiogenic therapies? This is a drug called BBL 111. And what it is the targeted anti-cancer viral gene therapy that basically is based on a non-replicating adenovirus that targets those angiogenic blood vessels and causes them to basically involute. And so you starve the tumor in a different way. So if your tumor has become resistant to Avastin, this is a way to come at it and hit it in a different way. And in addition, this drug causes some immune response as well. So it's a very interesting drug and very nice. This is the phase 1 data here in the bottom right with a lot of nice responses by CA-125. And it's entered a big phase 3 study called OVAL or GOG 3018. And they had a planned, it's still ongoing, it probably will finish accrual this year. They had a planned interim analysis that was presented at ASCO where they looked at the CA-125 responses. And you can see that at the bottom that you had about 58% of patients in the control or the experimental arm, which is Taxol plus the BBL 111 with a CA 125 response. And we're thinking that this is looking like a positive signal based on interim analysis. But the study will have to play out. So pretty exciting agent. And we'll see the results of this probably in 2022. This is not an anti-angiogenic strategy, but just a kind of completely different way of looking at these resistant tumors that we haven't tested before. So this is Gas6 AXL pathway. So Gas6 and AXL are really overexpressed in ovarian cancer, and especially in ovarian cancers that are destined to be resistant to therapies. And we've known this for quite a long time. And there's interplay between this pathway and a lot of things that make it seem like it will combine well. Like it has interplay with immune therapy, with mechanisms of chemo, with DNA damage response pathways, so PARP inhibitors. So this is a drug that may combine well with a lot of things. It interestingly has no activity as a single agent. Its sole purpose is in this particular drug, which is ABB 500, is to potentiate the activity of what it's combined with, which makes it like plays well in the sandbox. You can combine it with a lot of things because you don't really add to toxicity. And so there's a lot of work being done with this early on, but what's moved into phase 3 study is a very recently announced, we're site selecting now, is weekly paclitaxel with or without ABB 500. Very interesting statistical design that I can't go into, but really the point here is to potentiate the Taxol to hopefully work better without added toxicity, which is pretty exciting. So this is up and running, and this is GOG study 3059. So in conclusion, there's many examples of science-based novel therapies being studied. These aren't just like adding things on and seeing what happens. We really are trying to be purposeful about how we design these studies and really look at biomarkers. But clinical trial availability nationwide in places like Alaska and participation are key really to changing the standard of care in a positive way. And so with that, I thank you for inviting me to speak. It's my pleasure.
Hello and greetings from Richmond, Virginia. I'm Leslie Randall. I am the Division Director of GYN Oncology at the Virginia Commonwealth University. And I'm really happy to be back in Alaska to talk to you today. My talk is on immunotherapy for cervical cancer treatment, and I'll remind you that January is Cervical Cancer Awareness Month. So for our awareness, actually cervical cancer is the most common gynecologic cancer globally. And over 550,000 women are diagnosed annually, and there are over 300,000 deaths worldwide annually. So this is a major public health problem. It's the 4th most common cancer in women behind breast, colon, and lung. And it's the 2nd leading cause of death in young women in the United States. So the risk factors for cervical cancer are age, HPV infection, which causes almost all cervical cancer, also immunosuppression, HIV, and smoking are risk factors. HPV, or human papillomavirus, is a sexually transmitted disease, like pregnancy is a sexually transmitted disease, if you will. If you ever have sex, you can get exposed to HPV. So it's not, a dirty STD that is a marker of promiscuity. Anytime you have intercourse, you can get exposed to HPV. In the middle picture here, this is what we see when we look in with the speculum, that awful, uncomfortable instrument, and we see HPV infection on the cervix. And this is what HPV infection looks like on a pap smear under the microscope. So when HPV infects the cells of the cervix, all these fancy immune cells are supposed to clear it. And 80% of the time that works, but sometimes the immune system fails, or there's immunosuppression, and the HPV virus is allowed to grow. So our first line of defense against that is HPV vaccine. We're so lucky to have a vaccine that prevents HPV infection and therefore cancer. Here's some fast facts about the HPV vaccine. Already, HPV vaccine was approved in 2006, and already we've seen a 71% reduction in the types of HPV that cause cancer. And that's even without 100% uptake of the vaccine. So we're still trying to improve the rates of teens that are vaccinated against HPV. And we think that we could prevent about 29,000 cases of cancer a year with the vaccine. Obviously, prevention is better than treating cancer, because we often can't cure cancer, which I'll talk to you about further in my talk. We can do, if you skip over here to number 6, 2 shots of the vaccine, 2 doses of the vaccine are adequate to protect against cancer. And back here at number 5, we can give these ideally to children who've never been exposed to HPV virus through sexual contact at ages 11 and 12, when they receive other vaccines, including meningitis and whooping cough or diphtheria vaccine. And if patients aren't vaccinated, the second line of defense is a pap smear and an HPV test. So we recommend this every 3 to 5 years for women aged 21 to 65. And the screening guidelines are sort of complicated. They change frequently, makes it a little bit difficult for not only women seeking screening, but also their doctors to sort of keep up with what the current recommendations are. But this is grade A evidence, meaning this is, there's lots of good scientific evidence that this helps prevent cervical cancer. Now that we have 2 strategies, vaccine and pap smear with HPV testing, we have 2 strategies to prevent cervical cancer. So we have the tools in our hands that we need to eliminate cervical cancer from the globe. And the World Health Organization has prioritized doing just that. So they've recently launched a global strategy to accelerate the elimination of cervical cancer. And the goal is for cervical cancer to be eradicated by 2030, which, do the math, that's not very far from now. So, we have a lot of work to do. Here's what cervical cancer looks like in the United States from 1992 to 2017, when this was reported. The incidence of cervical cancer is declining, and that's most likely attributed to pap smear screening and treatment of pre-cancerous lesions. The death rate staying about the same, and really because we don't have good salvage treatments for women who can't have curative treatment. And interestingly, cervical cancer is a disease of disparities, meaning racism contributes to cervical cancer death, especially here all over the world, but especially here in the United States. And if you look at this map, this is a state of Alabama. And Alabama has a belt of counties that they refer to as the Black Belt, where this is a high proportion of African American residents. And in these counties, you can see these plus signs are access to an OBGYN. And this is much less so GYN oncologist. But you can see these counties, they're not even an OBGYN to serve these women. And these areas are marked by poverty and poor health literacy, a lot of distrust of the medical system due to not lack of education, but actually having been previously mistreated in the system. There's also a lack of money, lack of transportation to get vaccine, to get pap smear. And so this is a way in which racism really contributes to a disproportionate amount of death in these communities in cervical cancer. And if you look across the country, here you can see Alabama, also Mississippi, Arkansas, Louisiana, and parts of Alaska are affected by poor, high death rates from cervical cancer. In 2017, they estimated almost 300,000 women living with cervical cancer at any given time in the United States. So even though it's less common than in the developing world, this is still a huge problem in the United States. These are the summary of treatment. The treatment for cervical cancer is based on the stage of disease at presentation. If you look over here to the left, precancerous lesions can be treated with minimally invasive treatment or large biopsies. Early stage disease is often amenable to curative surgery, which is usually a hysterectomy. There are special types of hysterectomy that we call a radical hysterectomy. And some of these women are actually candidates for fertility sparing surgery, where they can have their cervix removed, but keep their uterus and eventually have a viable pregnancy and deliver a baby later on. About half women with cervical cancer come in with this early stage disease. Our real challenges for trying to cure women with cervical cancer are when they come in with what we call locally advanced disease, where the tumor has spread outside of the cervix, but is still located, within the pelvic area, so that radiation treatment, a localized treatment can be given. And this is given with a low dose of chemotherapy. And then for our patients with metastatic disease, meaning it's spread outside of the pelvis, either into the lungs or in the upper part of the abdomen or into some of the distant lymph nodes, these patients really have to have chemotherapy-based treatments. And we give that in the front line, meaning there's the first chemotherapy treatment that patients get, and we give sort of a more aggressive treatment with multiple chemotherapy agents. And then if that fails, which it often does, then we give a single treatment in what we call the second line of treatment. And right now, the most popular treatment is an immune therapy, and that's what we're going to talk about today. The last improvement for our radiation patients was in 1999, when we added a low dose of chemotherapy to radiation. There were 6 trials. Each of these bars represents a separate clinical trial, 6 clinical trials that all showed a benefit of treatment. If you're not familiar with this type of graph, you just have to take my word for it, that this showed an improvement in survival. And if you look at kind of the best outcomes we got with this treatment, about 67% of patients were cancer-free at 2 years. So a good rate of survival, but a lot of room for improvement here, with 33% of patients having a reoccurrence of their cancer within 2 years of receiving this treatment. So this isn't a population for improvement in treatment. That first line chemotherapy setting, this is the best treatment that we currently have. This is a clinical trial that tested chemotherapy with or without a biological agent that attacks the blood vessels in the tumor. This drug is called bevacizumab, and this addition of bevacizumab to chemotherapy alone improved survival by about 3 months, up to 17 months. And for the patients who had never had radiation, who were stage 4 at the time that they started this treatment, the survival time extended up to 24 months. So this is good, but we're not really curing patients with this therapy. And they often will go on to receive second-line therapy. And these are the response rates or the tumor shrinkage percentages that we see with these, what we call salvage treatment. So here you can see the lowest being 4%, up to the highest here being about 14%. So really not very good success rates with these treatments. And once women start these treatments, their life expectancy is relatively short, on the order of 6 to 8 months. So we've really got room to improve here. So if you go think back to that original graph I showed you of how the immune system is supposed to clear HPV virus from the cervical tissue, in any time that the HPV infection can incite in a state of immunosuppression by impairing the immune fighting cells, the T cells, or by upregulating cytokines, IL-6, that paralyze the immune cells, or by upregulating a molecule called PD-L1, which is a target of immune therapy. This allows the tumor to grow. So this is a very important or very rational target to improve our therapy for cervical cancer. Also, cervical cancer has a high tumor mutational burden, which means that the tumor mutational burden is a marker for susceptibility to immune therapy. And so really, of all the gynecologic cancer, cervical cancer has the most or the highest tumor mutational burden. And so theoretically would be the most susceptible to immune therapy. And so if you look back at that, if we're looking back now at that graph I originally showed you for second-line treatment with the low response rates, our newest treatment on the block is this pembrolizumab, which is an immune therapy. And this was the first study of immune therapy for second-line cervical cancer that showed a 12% response rate. But here, we don't have an overall survival reported, but the duration of these responses was very long, much longer than what we typically see here with these other therapies. So this was sort of a breakthrough therapy for cervical cancer. And this was the clinical trial that showed us those results. So women who whose tumors had grown back after that original chemotherapy were treated with this immune therapy. And in all of the patients, almost 100 patients that were treated, 12% of them responded. They had to have a biomarker called PD-L1 positive. We looked at that in the immune suppression slide to respond to this. And if they did not have PD-L1 positive tumor, they did not respond. So PD-L1 negative tumors do not respond to this therapy. And this is not given to those women. So that's another area of unmet medical need. And so the FDA has a special drug approval process where there aren't good therapies. The pembrolizumab treatment that we just talked about was approved and is approved for use in PD-L1 positive patients under this approval mechanism. A second anti-PD-L1 therapy called cemiplimab is in the phase 3 trial in cervical cancer, and we're awaiting the results of this study. There are other immune therapies, both single agent and combination, 2 different immune therapies that are under investigation in this setting. They have very good response rates. Here you can see 14% to as high as 45%. And these drugs are still kind of in the pipeline of being tested for cervical cancer, but showing a lot of promise. This is a different type of immune therapy called cellular therapy. And I remember when I was at this conference in Alaska, I guess it was about 2 or 3 years ago, and one of the pioneers, Dr. Heinrichs, in this treatment presented their results where they take the tumor and they take the T cells or the immune cells out of the tumor and grow them in a test tube. And then they send these back to the same patient from whom the tumor was obtained. And so these are personalized cells that are targeted against the patient's individual tumor. And they're given back to the patient to attack the tumor as the treatment against the tumor. And you can see very good response rate. These green bars are patients who have had complete responses or complete remission of their tumor. The blue bars are partial responses, 44% response rate here. So this is a very promising, we're still studying this, but this is likely to become available on the market within the next 2 years. So now we're trying to move these immune checkpoint inhibitor immune therapy treatments into the frontline chemotherapy. So adding these to that standard chemotherapy. We have 3 clinical trials ongoing currently. One is already completed. Keynote 826 is the pembrolizumab drug that's already approved. This is its confirmatory trial that will gain it permanent approval, which again, it's now under accelerated approval, but this is due to read out at any time. And then the ongoing trials, BCC and a trial called Fermata, and these are global trials. So these are still accruing patients. And then what about back to radiation therapy? Can we move checkpoint inhibitors to an even earlier line of therapy and improve our outcomes here? This is a lung cancer trial that showed that after chemoradiation for lung cancer, giving a maintenance checkpoint immune therapy called durvalumab, which is like pembrolizumab, you can improve survival. So this is survival time over placebo. This is a significant improvement here. So we think that we can duplicate these results in cervical cancer. And so we have 2 ongoing clinical trials, one called CALA and one called Keynote A18. And these are very similar studies that will compare maintenance with checkpoint inhibitor versus no further treatment after completing chemoradiation. And we're hoping to cure more patients with this therapy, or at least help them have longer remission times and live longer with this therapy. So these trials are ongoing and probably won't read out for another few years. So better is coming. This is actually where I live in Richmond, Virginia. This is the Robert E. Lee statue that was this year awarded the most influential piece of cultural change art in the United States. But here these new therapies are exciting, but they're also expensive. And so, my concern about these treatments is, how do we get this to everyone? We don't need to increase the racial injustice or the economic injustice that already exists in cervical cancer by developing therapies that aren't accessible to our patients. And so, I will sort of end my talk by encouraging everyone to, while we're excited about these therapies, we need to make sure that we are allowing them to get to the people that need them. So hopefully this was a good overview, and I thank you again for inviting me, and I'm looking forward to the panel session. Thank you.
Hi there. I'm Ursula Matulonis from the Dana-Farber Cancer Institute in Boston, Massachusetts, and it's a pleasure for me to speak today about PARP inhibitors and maintenance therapy and how treatment outcomes are improved based upon genetics. So I'm going to talk today about how do PARP inhibitors work, review PARP inhibitor trials for women with newly diagnosed, as well as for women with recurrent ovarian cancer, really trying to talk about, is a PARP inhibitor right for you? Which PARP inhibitor should you choose if you decide to go on one? And then also talk about some of the side effects of PARP inhibitors. It's really important to remember that ovarian cancer is not one cancer, and I know many of you know that, and hopefully we'll be able to talk a little bit about that today. But the key type of ovarian cancer that is most sensitive to a PARP inhibitor is high-grade serous or high-grade endometrioid. And these cancers, about 50% of them, have underlying problems in DNA repair. And that's called homologous recombination deficiency, or otherwise known as HRD. These tumors are also associated with BRCA mutations. And those are the types of cancers that are most sensitive to PARP inhibitors. This observation, this underlying genetic abnormality, makes these cancers more susceptible and sensitive to drugs like carboplatin, as well as to drugs like PARP inhibitors. Very important guidelines were published in early 2020, kind of giving clinicians really important information about understanding genetics and how to test women with ovarian cancer. So all women diagnosed with ovarian cancer should have germline genetic testing. So that's the type of testing that looks at whether your mom or dad may have passed on an abnormal gene that may have predisposed you to ovarian cancer, such as BRCA1 and 2, and other ovarian cancer susceptibility genes. There are about 11 of them total, and probably more. In women who do not carry a germline abnormal BRCA1/2 mutation, somatic or tumor testing should also be considered. Many folks, like I do, test both. We do both germline as well as underlying tumor testing as well. It's important that women who are diagnosed with ovarian cancer should have their testing done at the time of diagnosis and not waiting for later on, but really doing it at diagnosis, because it's important information to pass on to your family if you have a BRCA1 mutation so they can get tested. But it's also important for treatment as well. So this is a slide about PARP inhibitors, and the most important part of the slide are where the two big red arrow, blue arrows are and the blue boxes. So the mechanisms of action, how a PARP inhibitor works, is that it inhibits the function of an enzyme called PARP. And PARP's really important in repairing very early breaks or single-strand breaks within DNA. And then secondly, the PARP inhibitor basically makes PARP attach to the site of DNA damage and doesn't allow it to fall off. And that doesn't allow PARP to start to set off the cascade of DNA repair. So that's how PARP inhibitors work. The second blue arrow points to the 3 PARP inhibitors that are currently FDA approved for ovarian cancer. So rucaparib, olaparib, so rucaparib equals Rubraca, olaparib equals Lynparza, and then niraparib equals Zejula. And these are all very good PARP inhibitors. They're very good PARP trappers as well. So I'm now going to talk about the trials for women with newly diagnosed ovarian cancer that helps us decide when we should use a PARP inhibitor as maintenance treatment. SOLO-1, Dr. Moore, whom you're going to hear from today, ran this trial. And these were for patients who are only BRCA mutated and testing the PARP inhibitor olaparib. For PRIMA study, it was both BRCA mutated and non-mutated, testing the PARP inhibitor niraparib or Zejula. And then PAOLA-1 looked at both BRCA mutated and non-mutated. And this enrolled women with advanced ovarian cancer who were receiving Avastin, and olaparib was added to Avastin maintenance. So this is the trial design of SOLO-1. And the yellow parts are really the key parts. So all women in all these trials I'm going to talk about had advanced cancer, so stage 3 or 4, had to have high-grade serous or high-grade endometrioid because of that underlying homologous recombination deficiency, making these cancers more susceptible to PARP inhibitors. There had to be an underlying BRCA mutations. This is an important part of this trial. And thirdly, the cancer had to show response to platinum-based chemotherapy, meaning it had to have underlying homologous recombination deficiency. If it wasn't responding to platinum, then there would not be any reason to use a PARP inhibitor. And olaparib was used for 2 years of treatment. All women were either randomized to olaparib, it's a 2-to-1 randomization, so a 3-headed coin. 2 women received olaparib, and then one of the 3 received placebo. Study treatment continued until disease progression or disease growth. And then women with no evidence of cancer stopped at 2 years. But for somebody who had some cancer present at 2 years, they could continue on if they wanted to. The PRIMA study tests niraparib as a use of maintenance therapy after a response to carboplatin and Taxol chemotherapy. And the dosing of niraparib here is based on body weight and platelets. It didn't start off that way, but it ended up that way, and it's in the FDA label. So PRIMA design all the way in the left where the red box is, 2-to-1 randomization again, like Solo 1, 3-headed coin. 2 women received niraparib, 1 received placebo. You didn't know what happened. And then women took this drug, took the study drug for about 36 months, so 3 years, or until the cancer started to grow. And as I mentioned, everyone started off at 300 milligrams using the capsule formation, but eventually data emerged that if somebody had a body weight of 77 kilos, and that's about 170 pounds, and your platelets were 150, you could start off with 300. But if your weight is less than 170 and or your platelets are less than 150,000, you started off with 200 milligrams, really because of the effect on the bone marrow. And I also want to point out that the cancers in this trial were tested for HRD, or homologous recombination deficiency. HRD means that the cancer is more sensitive to PARP inhibitor, and HRP, or homologous recombination proficient, means that the cancer is less sensitive to a PARP inhibitor. And the third trial I mentioned is PAOLA 1, and this trial adds olaparib to Avastin or bevacizumab, and that's obviously combined with carboplatin and paclitaxel chemotherapy. So it's really important here, again, newly diagnosed women, stage 3 or stage 4, and you had to have received at least 3 cycles of Avastin to get into the trial. And this is the study design. So once chemotherapy finished, everyone received Avastin as maintenance therapy. In the top group, olaparib was added for 2 years. And in the bottom group, where the purple box is, women received placebo for 2 years. So these are the top line results. And I think these are all, these studies really show you kind of similar observations. They're all a little bit different, obviously. We can talk about that in our question and answer session. But for women who have an underlying BRCA mutation, and that can be either inherited from your mom or dad, or simply being within the cancer itself, there was substantial improvement in how long the cancer stays in remission for when a PARP inhibitor is used as maintenance following chemotherapy. And that was demonstrated with Solo 1, and that was demonstrated in the PRIMA study. So for the first 2 trials I mentioned. So very important. Overall survival results are not yet available. We certainly look forward to them. But right now, we have progression-free survival, how long the cancer stays in remission for. And that's pretty powerful results. Secondly, for women with an HRD cancer, meaning there's homologous recombination deficiency, meaning that there's sensitivity to a PARP inhibitor, but the cancer is not BRCA mutated, there was definitely benefit also to PARP inhibitor treatment, specifically niraparib in the PRIMA study, as well as when adding a PARP inhibitor to Avastin, specifically olaparib in the PAOLA 1 trial. That's the third study I mentioned. For women with an HRD negative cancer, or that's the other term is HRP, homologous recombination proficient, there was some benefit, but less so. And I think that's when you really do have to have a conversation with your doc about whether or not that's going to happen. There was really no benefit of adding olaparib to Avastin in women who had HRP cancers. Here's a slide that summarizes some of the side effects that we see and you may be experiencing on a PARP inhibitor. So drop in blood counts, fatigue, gastrointestinal complaints such as nausea, vomiting, diarrhea, constipation, reduction in appetite, interactions with certain medications. So it's really important to check with your physician. There's definitely a risk of a secondary leukemia or pre-leukemia myelodysplastic syndrome. It's about 1, perhaps 2% for women with newly diagnosed ovarian cancer, but it's up to 8% for women with recurrent ovarian cancer. And so far, that's been shown in women who have an underlying germline BRCA mutation. I think we'll find out more data for women who do not have a BRCA mutation. The risk is likely lower. So examples of drug-specific side effects: niraparib can cause hypertension or high blood pressure, tachycardia, headaches. Olaparib, a small risk of pneumonitis, meaning lung inflammation, an increase in the creatinine in your blood. Rucaparib can cause a transient increase in liver enzymes, SGOT, SGPT, also an increase in creatinine, increase in risk of cholesterol, and there's also a risk of rash. These are the dose modifications. I'm not going to go over them too much, but it's important that that your doc obviously know these dose reductions and dose modifications. For example, niraparib is given once a day. They come in 100 milligram capsules. Olaparib is twice daily dosing, and rucaparib is also twice daily dosing as well. So I have a few examples here. A 65-year-old patient of mine was diagnosed with stage 3C high-grade serous ovarian cancer in 2019 and underwent surgery with no cancer remaining at the end of surgery, and she was found to have an underlying BRCA1 mutation. I started her off initially with intraperitoneal chemotherapy. She couldn't tolerate it, switched to IV carboplatin and Taxol chemotherapy. She finished up 6 cycles total, and then started on olaparib in November of 2019. And she really has just had some mild nausea and fatigue, slight decrease in her red blood cell count. But I just saw her this month, in January 2021. Her C5 is stable at 9. She's currently without evidence of cancer, and she'll finish up 2 years total of olaparib in November of 2021 and then stop. A 61-year-old nurse is a patient of mine too, presented with abdominal pain in 2019. She had advanced ovarian cancer. She was deemed not to be an upfront surgical candidate, found to have high-grade serous cancer. No underlying BRCA mutation was found. She started carboplatin Taxol in August of 2019, did very well after 3 cycles of chemotherapy, went to surgery, had great surgery result, finished up chemotherapy about a year ago, December 2019. Her HRD test was positive, so she ended up starting off at niraparib 200 milligrams. Her weight was 62 kilos, and her platelet count was 200, so she qualified for the reduced dose. But by the 3rd week of niraparib, her platelets had dropped from 264 down to 110. So I actually held her till platelet count started to come back up again, restarted her at 100. Again, just saw her, I follow folks monthly, in January of this year, and she's doing great. So in the next few minutes, I want to talk about PARP inhibitors for platinum-sensitive recurrent ovarian cancer. So this is basically somebody who has platinum-sensitive recurrence, meaning that the duration between last platinum and evidence of recurrence is more than 6 months. And these are the 2 strategies. The top is platinum chemotherapy in red, and then a PARP inhibitor at the end. And then the bottom is Avastin maintenance. So you receive Avastin with platinum chemotherapy and then receive Avastin up front. The other paradigm is just to give platinum-based chemotherapy too, without maintenance. And that's something that obviously you're an oncologist and you would make that decision. There are important differences between the 2 paradigms I had on the previous slide. As I mentioned, Avastin started with chemotherapy and used as maintenance, but PARP inhibitors start after chemotherapy is done, because when one combines PARP inhibitors with chemotherapy, there's a lot of bone marrow suppression, and it's really prohibitive. Third point is all PARP inhibitors trials required high-grade serous or high-grade endometrioid tumors. We talked about that at the start. Avastin trials allowed all different types of histologies. And fourthly, the questions really arise: what's the best strategy for a specific individual? And again, that's something that you should chat with your doc about. There are 3 trials, phase 3 studies that tested the 3 PARP inhibitors I've been talking about at the beginning for patients with recurrent platinum-sensitive ovarian cancer. Niraparib, the NOVA study, SOLO2 olaparib, Lynparza, and an aerial through rucaparib or Rubraca. All women enrolled onto these studies had cancer shrinkage to their penultimate or second to last platinum and their current platinum regimen. So they really did have tumors that were very sensitive to platinum and thus a PARP inhibitor. PARP inhibitors I mentioned are started at the completion of chemotherapy, and the results of all three of these studies have led to the United States FDA approval of these drugs, as well as the European EMA. So it's really important that for all these trials, these are the bottom line results, that there's strikingly similar results in terms of how long the cancer stays in remission for, progression-free survival in BRCA mutated patients. And then there's decreasing benefits with less homologous recombination deficiency. So if a tumor is more HRP, there's fewer benefits. Doesn't mean there's none, but it's less. And that's where you and your doc need to make a decision. So I just want to tell you about a patient of mine, 59, as a nursing assistant, diagnosed with high-grade serous ovarian cancer, and had surgery followed by 6 cycles of carboplatin and paclitaxel chemotherapy. She was in remission until 2018, so she was diagnosed in 2015, and she was found to have a rising CA-125, and CAT scan showed recurrence. That was about 3 years after. I gave her more carboplatin. She got carboplatin pegylated liposomal doxorubicin, aka Doxil. Did well. She was found to have something called a RAD51D mutation, which will make her cancer more sensitive to drugs like platinum and PARP inhibitors. She started olaparib 300 milligrams twice daily in 2018. She had some nausea, some fatigue, but she's really doing well. And I also see her monthly, and she's doing well. So I have to make a decision at some point when to think about stopping. Just a slide about how PARP inhibitors were originally approved by the US FDA, and that's using them as single agents as treatment in BRCA mutated ovarian cancer. So the key take-home point here is the third line down, the response rates. They're up to 30 to 40% or so, and really showing that these drugs work in cancer that's BRCA mutated, and using it as treatment, not just as maintenance to prolong a response. So which PARP inhibitor should you choose, given the comparable and comparable efficacy of the 3 PARP inhibitors available for ovarian cancer treatment? Other characteristics will need to inform the choice and how you decide. Toxicities, drug-drug interactions, schedule, price, insurance coverage, access to special programs. And really the trials and FDA approval, all these 3 PARP inhibitors have similar approvals for recurrent cancer. They're slightly different in newly diagnosed cancer, which we talked about, but not for recurrence. And also importantly, your oncologist's familiarity with the drug. So in the last few minutes, just want to reiterate what we talked about, where PARP inhibitors are currently approved. So here, this is for women with newly diagnosed cancer. In yellow is the current approval. So 1 is maintenance treatment of women with germline or somatic BRCA cancer, ovarian cancer, who are in complete response or partial response to first-line platinum-based chemotherapy. And then the second is combined with bevacizumab for the maintenance of patients with advanced ovarian cancer who respond to upfront chemotherapy plus bevacizumab, and whose cancer is HRD. And that's for olaparib. For niraparib, there's a broader approval, not just for BRCA mutated, but also BRCA non-mutated. So maintenance treatment for patients who are in response to first-line chemotherapy. And for recurrence, all of these PARP inhibitors have very similar FDA approvals. So basically all 3 can be used as maintenance post-platinum-based chemotherapy and in response to platinum-based chemotherapy for platinum-sensitive recurrent ovarian cancer. And then secondly, they can be used as single agents for treatment in the setting of BRCA mutations. So I want to thank you so much, and it's a pleasure, and look forward to hearing about your questions.
Ovarian cancer last year. Luckily, I was caught in stage 1C, but my oncologist don't want to use a PARP on me because I wasn't advanced. So now I'm just being watched. Should I push for PARP to use now or just wait and see if I recur and use it next time? So if you saw this patient and she had just finished her chemo, Dr. Matulonis, what would you do?
Yeah, so great question, and wonderful news to hear that that you were caught with early stage cancer. So I would tend to agree with your oncologist and not use a PARP inhibitor as long as your surgeon really completely staged you and we are confident that you have an early stage cancer. I would tend not to, really, because you have a really good prognosis. The trials that we talked about today are for women who have advanced ovarian cancer, so stage 3 or 4. So I think that, because your prognosis is good, and because these drugs, as I mentioned, do have toxicities, I would tend not to, I would not offer you a PARP inhibitor.
Katie, do you agree?
Yes and no. I agree very much with everything Dr. Matulonis just said. The data, there isn't any data in anyone with stage 1 or 2 disease. It's a data-free zone. And so the data supports use of PARP inhibitor maintenance in women who've responded to platinum-based therapy and regardless of BRCA-associated cancers can go on to a PARP inhibitor for 2 to 3 years. I have had patients like you and really, I struggle because the data is very limited. There is albeit retrospective data in patients with BRCA-associated early stage disease, and the risk of recurrence is actually higher than the general population early stage disease, because when you look at all comers, it's a much different distribution of histologies for stage 1 and 2. There's a lot of clear cell and endometrioid, and those are cured with surgery, or they're not. The chemo probably doesn't matter. BRCA-associated cancers are high-grade serous, all of them. And so the risk of recurrence, I think, is higher. And you have one chance to cure. And so I think that it's honestly a shared decision-making discussion. I very much acknowledge there's no data. I agree there is toxicity. The biggest toxicity we worry about is secondary leukemias, which I think is a real toxicity that we have to talk about. But I do think that if you recur, you're no longer curable. And so it's, I think, and we're never going to do the study, to be honest. So I think your oncologist is correct. I think their interpretation of the data is correct. But I worry about patients with BRCA early stage disease. I don't think we know enough one way or the other. I'm just going to acknowledge that clinical equipoise.
I think the bigger controversy comes in stage 2. Stage 1, I would, stage 1C, I guess I'd want to know a little bit more and, understand why this is being called the stage C. And that's why I kept open the, as long as you had, obviously appropriate standard surgery. But if it's really a stage 1C, I probably would not.
Yeah, everyone that I've seen in consult's not been fully.
Yeah, no. It's good to discuss it. It's good to discuss it, of course.
Yeah, I think it's hard because the benefit was so great, and like you said, we'll never do the study in early stage. I struggle with it too. Truthfully, if I have a patient who's really motivated to use the PARP after treatment, then I go along with it. I help them out.
Yeah, stage 2 I will, but stage 1.
I use it in 1C because the risk in a high-grade serous ovarian cancer, even with 6 cycles of chemotherapy, is 20% recurrence. And if you think about the hazard ratio, if you can decrease that by, 2/3 or more, even 7, 3/4, we do a lot. We do a lot for that kind of risk reduction. So, so when this comes up, then if somebody like this was considering doing it, we start PARP inhibitor right after chemotherapy. So this comes up sometimes where you see a patient and they've had their chemo, and what interval would you think that it's not appropriate to start maintenance therapy? What are your thoughts about that?
You mean?
Like if somebody was a year out from chemotherapy, I wouldn't give.
Would not.
No.
Right.
No.
But if somebody was 3 months out, I would.
Yeah, 3 months.
I think that's the longest.
Yeah. Is 3 months the longest for you?
Okay.
Well, sometimes it just takes counts to come back. They really want the counts to recover. So sometimes it does take, 2 months, 8 weeks, 12 weeks. So yeah, I think 3 months is very reasonable.
Yeah.
6 months. Did you say 6 months that you went? Yeah, 6 months. I agree.
Well, I mean,
Yeah.
I have my own polar bear here.
So cute.
So I had to pretend I was in Alaska. So I got a polar bear. I think, so the studies all started the PARP within 8 to 9 weeks. And so you have that kind of built in, to those survival curves. They start a couple months after finishing chemotherapy. And so I think from that point, another 3 months is completely acceptable. And I might even go to 6, to be honest. Like, I want people to have access to the drug. But I think beyond that, and I wish we could show some of the slides, but in SOLO-1, when we're talking about a BRCA-associated cancer, SOLO-1 patients were very different than PRIMA. About half of our patients were stage 3. They had surgery first. The surgeons got everything out, and they were in complete response. So, and they all had BRCA. So the best prognostic group of patients you could ever hope to have, they started their PARP with no visual disease. And the survival curves, the biggest change in those curves is in that first 6 months. Like, that's really where you see the separation. And once you're out to kind of 12 to 18 months, the curves start to become more parallel. Like, the event rates in each group are the same. So I think the benefit in that population is an early one in that population, which I think an early stage patient would apply to. So yeah, I wouldn't go too late. A year would make 0 sense.
Okay, I'm going to move on to some other questions because I want to have time to get to them. We have about 10 more minutes. So this is for Dr. Randall. Would a sexually active woman over age 65 benefit from the HPV vaccine?
There's a lot of debate about that. The approval actually got expanded to women up to 45 because we thought, okay, with a new partner, you could get exposed to a new infection. The benefit is clearly prior to any sexual contact. That's the greatest benefit. After which you've probably been exposed to some HPV. The rationale to give it later in life is that even if you've been exposed to HPV, you've probably only been exposed to one high-risk type, and you may benefit from being vaccinated against the other 8 types that are in the vaccine. The problem is how the immune system works. So as you get older, the immune system doesn't produce as robust of a response to a vaccine. And so, they expanded the approval. It used to be from 11 to 26, and they expanded it from 26 to 45 to account for new HPV infections. But most doctors agree that, the immunity response is less at that age group. And then after 45, we really don't have any data to show if the vaccine is effective or not. So, if I have patients who are really motivated to get vaccine, I give them this explanation, and then I can't say I've vaccinated anyone over the age of 45, but the vaccine is pretty much harmless. There's really low rate of any severe side effects from the vaccine. So I don't think it would be harmful, but I don't think it would be that helpful.
So another sort of related question for you, Dr. Randall, is are screening guidelines different for girls, women who did receive the HPV vaccine as children?
Not currently. So currently you're supposed to follow the same exact guidelines, which kind of doesn't make sense. If you have the vaccine, you ought to be able to get out of the pap smears. But right now we don't have enough data on, long-term. We know in the clinical trials, it was almost 100% effective. There's no reason to believe that it won't be in the general population, but the general population, the immunity might be different than it was in the women on the trials. So we have to wait until we get longer term data. I showed you a graph in my talk about the incidence of cervical cancer and how it's going down. Well, that really only reflects pap smears. That doesn't yet reflect the vaccine. It's going to take probably 10 more years to get really good data on how the vaccine has impacted the actual occurrence of cervical cancer. So until then, the screening guidelines remain the same.
Okay, this one's for you, Dr. Moore. How widely have TIL treatments been used for ovarian cancer? And I would add, and where would you be able to access them?
Yeah, that's a great question. Not incredibly widely yet. There are several studies. We have one open in Oklahoma called AdaptImmune, which is more CAR T than TILs, but I think you're asking in general about cellular therapeutics. So they're really just starting to pop up, I think, at some of the major centers. And in fact, we just treated our first 2 patients with ovarian cancer on that protocol within the last month. We were on hold for a while because we did not want to risk inpatient with COVID. So we kind of put that program on hold a little bit last year, and we've just really recently started revving it back up. So I can't give you any experience in terms of efficacy because our patients just got theirs. Where you would get it, honestly, right now is at places that have intact, what we call cellular therapeutic programs, where they're doing CAR T or TIL therapy in hematologic malignancies where it has an approved indication, and you have cellular therapeutic teams that really understand how to manage infusion of the product and the potential for these infusion reactions called cytokine release syndrome that can be quite severe if you don't know what you're doing. They know what they're doing, and so it has a much higher, it's like having a high volume surgeon. You want to have somebody that's not having to look it up on the way to your room. So right now it's, I think, pretty limited to big academic centers. And probably Dr. Matulonis can comment on this as well at Dana-Farber. And we'll see the solid tumor studies, I think, are probably a year old. So I think it's going to be a bit until we see what the efficacy rate is, but super exciting. What do you think, Ursula?
And I'm typing in answers to your correct questions. So you're talking about the bispecifics?
CAR T.
Oh, CAR T. Yes, sorry. Yeah, no, I think we're just starting them, and I completely concur. I mean, you really need a team who is expert in this, and probably, a faculty member or 2 who are really, embedded in the inpatient world to do this work. But it's just starting, and I agree, it's very exciting because I think, as we've talked about today, our initial entry into immunotherapy has not been, at least in ovarian cancer, has not been as productive as we would have hoped. So we do need new ideas and new therapies. I agree.
Yep.
Okay, this is one for Dr. Matulonis. Are PARP inhibitors used much on low-grade serous ovarian cancers in patients who are BRCA negative?
Okay, so the answer to this one is no, and really because of the fact that low-grade serous cancers are really quite distinct from high-grade serous carcinomas, where high-grade serous cancers have, as we've talked about, underlying homologous recombination deficiency. Low-grade serous cancers are unfortunately not particularly sensitive to drugs like platinum or to PARP inhibitors. They're typically HRP or homologous recombination proficient. They sometimes have RAS mutations. So the answer is no. So I do not use PARP inhibitors in low-grade serous. I guess occasionally you might find a BRCA mutation, but it's extremely, extremely rare.
So I have a couple questions that I'm just going to ask because we went through most of our questions. And one is, you kind of mentioned this, Dr. Matulonis, but all the recurrent trials with PARP inhibitor maintenance continued it indefinitely. So when or do you stop in a patient who is without evidence of disease in the recurrent setting and on maintenance PARP inhibitor? And does that matter based on their biomarker?
Yeah, it's a really good point. I mean, I think our folks who are going to do really well on long-term PARP inhibitor use are those who have underlying BRCA mutations. And I have some women who are on one of my colleague, Joyce Liu's 09293 protocol. So this is, 2009. We're now 2021. So I've had women on PARP inhibitors since 2009. And I think, with no evidence of cancer and with the Solo 2 data that is starting to see an increase in, a pretty high risk of acute myelogenous leukemia and myelodysplastic syndrome, I am definitely, once that Solo 2 data came out this summer, have started to talk to them about really seriously stopping the drug, because their long-term, they're doing very well. And I think they may be cured of their cancer. So every conversation is different. Some welcome the chance to come off of a drug that they've been taking for over a decade. And some are very apprehensive. So when would I start? I'd probably start maybe even 5 years out. And again, that's pretty arbitrary, but that's sort of when I'm starting to think about it. As long as they're doing okay. Obviously, if somebody's on a PARP inhibitor and they're showing signs that their bone marrow is suffering with some bone marrow toxicity, then I think about it way sooner.
Well, how do you guys feel about that?
I'm thinking about it too. I think that one of the other big kind of paradigm changes that happened last year, and we'll see when the paper comes out, but the study Desktop OVAR kind of brought secondary cytoreduction back into the practice for selected patients. And I believe that data there, I believe that's true with an overall survival advantage. So the patients that, I have a few women who have BRCA associated cancers who were 5 and 6 years out when they recurred with oligomets. So they're resected, they started their chemo with nothing, they ended with nothing, and now I have them on PARPs and we're approaching 2 years. I'm thinking about it, we're talking about it. It's uneasy because I want them to, be on it for 9 years. I don't want to stop it and then they're, resistant. So it's, again, another area I think of clinical equipoise, but the AML rates, I know that there's a lot of patients listening, but you guys should know what we think. AML MDS isn't fixable. Like, we can kind of temporize it for a while with some azacitidine and keep things going, but that's basically a terminal event. We're done really fighting your cancer at that point, unless for very few we can do a bone marrow transplant, but that is really in left field in a special situation. So it's a big concern to us. So you want to make the right decision on either side.
We have a good question, but I think, Joni, we're out of time, right? I just had a question come in. We're out of time though, right?
We are sort of out of time. I'm so sorry.
We were getting really great questions from the audience, and thank you guys for your enthusiastic participation. Thank you to the panelists and for such great talks.
Thank you so much.
Absolutely.
Nice to see everybody.
Thank you all
Nice to
so
see
much.
you all. Thank you.
All right, take care. Bye.
Bye, everyone.
Bye.